Hi, everybody. I'm Susan McDaniel from the Institute for the Family, and I'm very excited today for you to get to meet and hear from our colleague, Deepu George. Deepu completed his PhD in Human Development and Family Science with a specialization in family therapy from the University of Georgia in 2014. He completed an internship in medical family therapy and integrated care at Duke's Southern Region AHEC at the Family Medicine Residency in Fayetteville, North Carolina. Dr. George is now Associate Professor of Primary Care and Community Health and Director of Integrated Behavioral Health at the University of Texas Rio Grande Valley School of Medicine. His work focuses on implementing integrated behavioral health models in primary care. Deepu has secured literally millions of dollars in foundation grants to implement and evaluate integrated primary care in rural southern Texas. He's published 17 peer-reviewed articles and done many presentations on integrated care. He also acts as a behavioral health consultant and teaches primary care residents didactics and skills related to primary care behavioral health. His research focuses on social determinants of health, physician resilience and well-being, community capacity building, and health disparities in the Rio Grande Valley. He's very active on various communities at the University of Texas Rio Grande Valley, including serving on the Promotion and Tenure Committee and the search committees for Associate Dean for Faculty Affairs, the chairs of Psychiatry and of Neurology. On a personal note, I've had the pleasure of getting to know Dr. George through National Integrated Care Circles, and what a talented and special person he is. He's been the president of the Collaborative Family Health Care Association since 2018 and put on literally the best conference I've ever been to celebrate the 30th anniversary of CFHA. He's completing Rice University's certificate in executive coaching based on the International Coaching Federation. And to show how much younger he is than me, he co-hosts 2 podcasts for CFHA, and he's developed an app to improve the wellness of physicians and has $1.5 million of investment money for the app. Right, wow. So all this sounds like a very successful academic career for a talented person, but there's more. I'll mention things that I suspect you wouldn't guess. First, Dr. George is trained in sports medicine and has a certificate of mental health in elite sport from the International Olympic Committee. And in addition to all that you've heard, he's been attending seminary and will become an Episcopal priest sometime in the next year. I know. All right, so I give you Dr. George.
I should have you come talk a lot of the times just to boost me up, because it definitely doesn't feel like that all the time, but I really appreciate the love. Good afternoon. All right, you guys are eating, so I don't want to disturb that, but I'll get to the talking. I want to start by expressing my really profound gratitude for being here. I learned about family systems as a graduate student in India, and learned about all of the crazy things that we do in therapy and with families, and I was blown away. And then I pursued my doctoral training, and you don't have to go too far in your training to start hearing Rochester, Susan McDaniel, George Engel, John Romano, all of these names. And so I feel very privileged to be on hallowed grounds and also to be amongst the legends who've made my career possible. So I'm very grateful for that. It's a big deal. I told my parents it's a big deal, and so they are finally catching on. So thank you for bringing me to Rochester. A little context from where I come from as we kind of look into the talk and what we want to do today. Most of my clinical work is focused on workforce education, and that really looking at physicians on one end and then also training behavioral health professionals to be familiar and nimble and agile in a primary care setting. So a lot of my thinking kind of comes from that process about some of the questions I want to pose for you today as we go through the talk. And so the invitation for you today is to think about our field, whether you're in psychiatry, psychology, or integrated care, about our next episode of what we would do in the world, and how the biopsychosocial model will impact regional and national healthcare outcomes in the future. In other words, how do we particularly think about barriers that may be preventing access, and how do we disrupt those to improve access? To look into the future and think about those things together. So I don't want to get too ahead, so let me kind of start with the objectives for the talk, because this is a grand rounds and I must have objectives. And here are the few things that we'll go over today. So one is learning how to apply the eco-cycle framework to map the developmental cycles of mental health models, mainly the biopsychosocial model. Examine the sources of rigidity trap that maintain barriers to growth, and formulate pathways to disrupt stagnation towards renewal of mental health models. And so the last two kind of like merge together in the latter half of my talk, so you'll kind of see what I mean by that. So to help us get started, let me begin with a story. It is a story about two companies that has altered how we, all of us, consume entertainment. So let me start with the first company here. It's Blockbuster. I'm not sure how many in the audience remember a physical store. I have a few hands up front, none in the back. And so, okay, so everybody remembers Blockbuster. It is definitely a relic of our recent past, but if you are unfamiliar with it, you literally had to go to a store to rent a movie. Crazy, right? Not how it works today. But they were a very big business. They were booming. Between 1985 and 2000, the company experienced an explosive growth. At one point, they were opening a store about every 17 hours. The customers would go visit the stores. They would rent movies and videos, and they were initially unprepared for the DVD onslaught, and you'll learn later on in the talk, they were unprepared for a lot of things that came their way. And one of their profit drivers was late fees. So if you turned in your videotape late, then you got a fee, and that was actually one of their drivers of how they made any money. And another company, around 1997, which I'm sure has taken too much of our collective hours over the last several years, Netflix launched, and they entered the business, but they started with the DVD era. And right off the bat, they did few things that removed the pain points that Blockbuster had. So one was the inconvenience of store visits and literally going into a store. The frustration of late fees, they got rid of that, and unlimited access. If you subscribed, you had unlimited access to any number of DVDs that you want to borrow, and you don't have to send them back next week. You can send them back whenever. And they had their struggling phases in the beginning. They had to figure out a mailing process. They did not have enough DVDs. There's stories of Netflix employees running to Costco and Walmart, buying DVDs so they can send it in the red envelope. So everybody remembers the red envelope? Okay. All right. So we have some people who remember all this history. So that's good. So that was Netflix, and they were trying to compete with Blockbuster. And the legend has it that in Dallas in 2001 day, there was a meeting between the leaders of Netflix and Blockbuster, and they had made a proposal to have them bought out for $50 million, and the CEO not only dismissed the offer and kind of thought it was a joke, he kind of counted it as a dot-com bubble, that this isn't going to last too long. And, you know, they had some losses with Enron in 2000, but Blockbuster was still the big boy in the block. And so then, you know, history continues. They were undaunted by what they did not get from Blockbuster. They went public and sold some shares and they made some money. They started seeing profit in 2003. One of the key things that Netflix was doing from the early days was they were paying attention to the developing infrastructure that we take for granted today. So our phones, our access, 24-hour streaming capabilities, all of that was not usual for us a few years ago, and it is today. And so they developed their first algorithm in 2000. Algorithms control our lives today, whether you like it or not, especially if you're watching Netflix. So what they did is they created an algorithm where they would predict movies that you like and introduce you to new movies in 2000. So if you were a subscriber back then, you discovered new films on their behalf because of that. And then at the same time, around 2003, in an earnings call, the CEO called the Netflix as they're nothing, they're none, they're just a gnat, so we don't have to worry about them. And so Netflix just kept on doing what they did. And in 2007, for the first time, we use the word streaming all the time today, but it was not a word before 2007. And so they introduced the first streaming service, a novel move that would really change entertainment forever. And that was still not where we are in later developments of Netflix. Now, Blockbuster started catching on in 2007. And they went all out and did this thing called Total Access, where customers can go in and rent a DVD online. And they thought because they had stores, the exchange would be a lot easier. So there was all this workarounds. But they realized they were losing about $2 per DVD rented by the time they calculated the total cost of it all. And this is the earliest when Blockbuster was beginning to embrace technology. It's 2007. Somebody has been doing it since 2000. And so the long story short of their saga or their large history is Netflix in 2013 launches House of Cards, which was a big get for them. In fact, HBO and a couple of other services were looking for that. Netflix went and met with the director and basically said, we're going to give you 2 seasons, fully committed, $100 million, not a lot of production notes, and they won them over. So House of Cards kind of becomes like this onslaught of production from Netflix that changes how we all consume entertainment today. Les Moonves, who was the head of CBS at that time, remarked, do they even know how TV works? Because they released all episodes in one go. So these are some really daunting moves on their part. They were acting ahead of where the industries were. They weren't kind of captive to their structure. For Blockbuster, I think they were really stuck on the brick and mortar business, the rental business, the late fee business, and all of that, right? So you can kind of begin to see where they kind of launched into the stratosphere in a much different way. So 2010, $1.1 billion, after losing that much, they filed for bankruptcy. And they were too invested in their own business and infrastructure. They didn't want to let go or rethink the assumptions that held their worldview, and did not adapt for the equations of new growth factors that were entering their stream, whether they liked it or not, right? So why are you learning about the history of Netflix and Blockbuster at a Grand Rounds in Rochester? Well, I'm glad you asked, because I have the answer for that. So you can see a pattern of growth and renewal that is occurring in this cycle, where Blockbuster fails to renew. They grew, but they failed to renew. On the part of Netflix, their story continues, right? Because I think they're a good model of how they've continued to take feedback and begin to do things with who they are. Their next target that they went after was HBO. And then I think the HBO CEO made fun of them, saying that they are as strong as the Albanian army. Albanian army is not very strong. So then all the Netflix employees went and got Albanian army insignia on their shirts and they walked around, right? And so they forced HBO to change their model. As you can see in the last few years, they went away from streaming. They're doing live events now. I mean, it's part of their model. They got rid of DVDs, so they let go of some things to adjust to the market that was coming out, right? So in this framework, I want to introduce you to something called the eco-cycle planning framework, which kind of tracks for us their story. There is 4 distinct stages and few processes in between. Gestation is when an idea is born, and in order for it to be born fully into the world, it has to kind of survive what we call the poverty trap. And the poverty trap is where ideas get killed. Like if it doesn't have enough sustenance, if it doesn't have enough backing, it can go away. And once you're kind of born into the world, you kind of have to grow, just like we know in our developmental cycles. And from there, you enter a position of maturity as an organization or as an idea. At this point, you can either pay attention and learn, or you might get caught in the rigidity trap, because as the plowing occurs, sometimes the plowing and the creative destruction is not plowing that we intentionally or voluntarily want to do. It's plowing the elements of our nature and elements of our markets do to us. And so if you are nimble and agile in that process, you move towards renewal and kind of starting the cycle again in that process. So everybody with me so far? Yeah? And you can kind of begin to track where Netflix's and Blockbuster's story kind of falls along the continuum of the cycle, right? We can keep following their story for the future and see where it leads and see if it takes us anywhere else. So why does this matter for us? I think one of the things that I want to do with you today is just really map the growth of the biopsychosocial model from a very 30,000-foot level point of view. And it is a little bit of history, and so nothing is more nerve-wracking than recalling history when people who made history are in the room. So, Dr. McDaniel, if I mess up anything, you can give me notes afterwards. I will incorporate them into my model. So if we kind of take that, we kind of look at the early 1970s with University of Rochester beginning to play a big role. We have all of the names that make biopsychosocial thinking not only in practice, but write about it and promote it in a big way. And I would imagine some of this may have started much before, when John Romano and George Engel were working together in other institutions before they came to Rochester. And the need for a new model, a challenge for biomedicine, becomes the prophetic call that we needed to kind of jolt us out of the ways that we typically thought about medical care. And Sandy Blount, who is one of our CFHA luminaries, in one of his history books, he talks about a practice in 1970s, somewhere in New York, as having the first experimental behavioral health integration program back in the 70s. And so I would say 1980s, we were beginning to kind of be in that poverty trap area. Would this idea march on to the future to become the promising thing that we know as it is today, or would it do something else? So a couple of seminal events is Family Systems Medicine Journal, which Dr. McDaniel had a role to do with later on. Family Therapy and Family Medicine toward the primary care of families. This was written by Bill Doherty and Mac Baird. I think they were at Iowa at that time. So they were in Iowa at that time. And so Rochester, Iowa, so you can kind of see the love spreading a little bit. And Carl Whitaker, who is a family therapist and psychiatrist, he wrote in the cover review that these two super docs may start a whirlwind. They think systems, talk context, and breathe medicine. And I think we are a product of that, all of us here in this room. We are moved by that call and the experience. 1984 in Cherokee, there's things starting with Cherokee Health Systems in Tennessee, then Systems Consultation, a New Perspective for Family Therapy by Dr. McDaniel and Dr. Weber. And Patty Robinson and Kirk Strassel, they begin early experiments with Wayne Caton, which eventually becomes the collaborative care model, right? So this is the 1980s. So the fragmentation fighters, as I like to call them, they were trying to better operationalize the biopsychosocial model, bring physicians and medical providers and behavioral health clinicians in the same pod, and make sure that patients get this model of care by design, not by an accident or because of one provider really likes to spend time with their patient, right? So we were really rewiring the system to do that. And it also occurred disparately across the country. And that disparate nature soon began to have regional and national imaginations, right? And that kind of led to a lot of things. So in 1990, family-oriented primary care comes out. And in 1992, medical family therapy, a biopsychosocial approach to families with health problems comes out. And so this is both from Rochester under Dr. McDaniel's vision and writing. Cherokee Health becomes Cherokee Health Systems. They went from a community mental health center to a primary care-oriented center to signify their comprehensive role in integrating physical and behavioral health. 1994, United States receives its first definition of primary care by the Institute of Medicine. And in that same document, Frank Degree, the chair of family medicine from Colorado, wrote one of the first compendiums to the IOM document on mental health and primary care. And there was a newsletter titled Working Together creeping up there, which would later become the impetus for collaborative care, or CFHA as an organization. 1995, the first impact on depression in primary care trial results come out, published by Wayne Caton, and it's the early seeds of what would become, as I said before, COCM. And we have the first ever Collaborative Family Healthcare Association conference that year, right? So 1995, 4 really launches that. And there are a couple more bigger things coming. And one of the big guides that we still use today is what Dr. McDaniel and Dr. Baird and Doherty worked on, is the guidelines for integrated care and levels of integration. If you kind of walk through a clinic, if I see people behave, can I say, which level of integration are they at? And Kaiser Permanente launches the first implementation of primary care behavioral health in their health system, right, in 1998. 2000s, we're beginning to grow. I like to think we've grown, we were born by then, and we're kind of gaining some energy. The US Air Force adopts the BHOP program, and that becomes a big boost for a large system to adopt something as big as that. The VA system kind of launches into a version of primary care behavioral health integration. And family-oriented primary care comes out, the second edition. And Cherokee Health Systems expands a lot of their services by then. And 2007 and 2009 introduces 2 of the books that most people have, is behavioral consultation in primary care, and then kind of like the intervention-oriented book from Chris Hunter, Jeff Goody, and a whole bunch of other psychologists. And 2010 was a big year for us because the Academy was formed for integrating behavioral health as part of AHRQ. And 2013, we finally have the lexicon for behavioral health and primary care integration, which right around the time when I was going into medical family therapy and integrated care, it was very exciting to kind of read through that PDF. It's a very boring PDF, but if you're nerdy enough, you're going to get through it. And SAMHSA adopts the earlier work that Dr. McDaniel and colleagues did to actually propose kind of national standards for integration. Am I on the right track with history? So okay. I'll take notes later. And so in the 2010s and 2020s, we are kind of maturing. And I want to make the case to us today that as a field of integrated care and other respective professions that you're part of, we are in a mature phase. We're harvesting the benefits of our toil from yesteryears. And we have books and articles and practices, behavioral health integration jobs are a lot more frequent and familiar to the world out there. I know you guys train a lot of people every year through the intensive who come from outside to kind of get that experience. We've had several special editions in scientific journals that that kind of talks to the maturity of our field. CFHA as an organization turned 30 last year, and so that's a big deal. So where do we go from here as we kind of think about the next phase of our growth? Do we want to be Blockbuster or do we want to be Netflix, right? Do we want to adapt and be agile in the things that we think about and get into a habit of right sizing or being the right relationship with? Or do we just want to keep our head down and not think about the things that are coming at us, right? So that's a question for us. And so when we kind of look at the model overall, we want to kind of get a sense of how did we fare out? Because I think, in my estimation, either the gestation was 1970s and poverty trap was 1980s, or it happened some other way. Regardless of how we look at it, we're still at a very mature phase, right? We've kind of moved through all the challenges that we needed to kind of get to where we are. So the question for us is, what forces do we need to right size against to strengthen the biopsychosocial model for increased reach? Access is still a big issue for regional, I'm sure regionally. I live in South Texas, really South Texas, all the way next to the Mexican border. And access is a big issue for us, right? And so I don't think we've solved this issue. One of the assumptions that I'm working under is that the United States will never get primary care right? They will never make a front-end investment in primary care policy. So we kind of have to work with what we know and what can happen, right? Which is, we have to be hopeful in a very constrained situation, right? We're all used to that in our work roles that we play. So the Health and Human Services, one of the bigger victories, which I'm not sure if it'll stand, in 2023 had released their roadmap for behavioral health integration. And one of the things that they talk about in there is this idea of a whole society effort. And they want behavioral health integration into child services and social people who seek social assistance everywhere, right? So that we can kind of be the unique, not the unique presence in one-off department, but like the main ingredient, like the key ingredient in a lot of the things that we need to do in healthcare. So last year, I started thinking about this because we were leading CFHA through a strategic plan, and we kind of used this framework to help us cast out into the future. I had a chance to sit with Parinda Khatri. Dr. Khatri is the CEO of Cherokee Health Systems, and we both looked at our reading, our thinking, and said, what are like some of the factors that we need to consider as we march to the future? What we did not anticipate at that time is the current political climate and the threats to different things that are happening in healthcare, but we'll kind of resolve for that and be agile and adaptable as we always are. So here are the 6 things that I'll kind of cover with you. Is that 6? 1, 2, 3, 4. Yeah, that's 6 things. And as you listen to these things, think of things that are not on the board, right? This is not an exhaustive list. This is just some things that we feel like we have to contend with. And take notes. Hopefully we can have a discussion, question, and a conversation afterwards. So the first thing is zip code, not genetic code, right? So it's the 80-20 effect. And part of that 80-20 effect is the idea that about 20% of health outcomes are determined by clinical care, and about 80% of outcome, they come from social and economic factors, right? And so there is a lot more driving the healthcare outcomes outside of our immediate influence, right? So that's one of the things that we need to think about. Not that we're not thinking about it. That's the other thing that I would want to say. I don't think none of these factors are new to integrated care because we work in messy systems and we have to encounter these. I think our contention is that we kind of had to put this in our viewfinder with a lot more emphasis and can't lose the mark when they're trying to flood the zone and other things, right? So we can't miss the mark on that. Robert Wood Johnson talks about economic status, employment, education, housing, nutrition, crime, pollution. Rush in Chicago with a nonprofit in their area, they're doing some interesting things on blood pressure management and job security and employment opportunities, and that is a good example of that. At the Episcopal Health Foundation in Texas, they surveyed Texans who are on various insurance, mostly Medicare, because they're working on Medicare access and expansion. 65% of patients, these are not people sitting in ivory towers, they said they would be healthier if the state invested in non-medical factors. And 55% believe that health insurance should cover non-medical drivers of health, right? Especially when we know this fact about the 80-20 rule and zip code being your best predictor of life expectancy. If you guys are curious, if you go to their website, they have a Healthy Places Toolkit, which is a practical guide to improving community health. So they actually have policies, programs, and procedures to kind of enact some of these things in your clinic. The next thing that we are kind of beholden to, whether we like it or not, is artificial intelligence and the agony and the ecstasy that it offers, right? So a few things to kind of think about here. It is poised to revolutionize healthcare across multiple domains. It is supposed to reduce human error and improve diagnostic accuracy, enhancing population health through predictive analytics, which I think I can get behind, supporting personalized mental health treatments, maybe, and preventing clinician burnout. I'm just giving you my bias. As you look at this list, how many of you are thinking like, yes, medicine? No one's going to report you, so this is good. Okay, good. Yeah, and I think it's one of those things that you can't get away from, because it is here. It is in our phones. It is in our conversations. I also then thought about the time when other technologies were introduced with all kinds of promising benefits to us. And so cautionary lessons from EHR implementation. It was supposed to be a lot of things that we resolved through that, immaculate data, better care, but we still have not kind of really met that, right? And it works, it's more frustrating. Most of us who have to deal with it, it's not very fun when it doesn't do what you want it to do, when it doesn't give you the data that you hoped that you would get. And so the risk of viewing AI as a magic bullet for healthcare challenges, we want to caution against. So more discerning stance than we got it figured out. There are lots of error rates and hallucinations. I use AI for a lot of things, and I double check most of those things because sometimes they're just making up stuff, including citations. So you might feel like you have like 10 citations for your article, but it's not real. So you better do your homework when you use AI. And then the other thing is there is very concerning evidence that talks about racial and gender bias in AI systems. Unmasking AI is a book written by Joy Belawami out of MIT. The AI facial recognition software could not recognize dark-skinned faces, including faces of Michelle Obama, Oprah Winfrey, people that we know in the community, who are very well known in the country. And so being aware that models that are training from the existing data, which also is underwritten by all kinds of biases and things that we're not even thinking about, right? So when we integrate that into a medical environment, how do we want to account for that? So our caution here is to be more Netflixy here than Blockbustery, is just discern and know that it's not going to solve all our problems, but it might be a great aid, and kind of keep it as that. So that's kind of my little soapbox on AI, not that much. Technology and populations really accounting for the young and the old. So there is the digital natives and the digital immigrants. And so for older adults, they are at higher risk for digital exclusion. So we have Epic in our system, we have MyChart, and so a lot of the times I hear physicians say, well, I'll send it to your MyChart, you can review it there. which is great, right? Like immediate, accessible, but there's a lot of people who just doesn't operate that way. And we have a rising number of seniors in our population. And so we may want to correct for that and think about what workflows and things do we need in our systems. Now, younger generations, they may find lesser value in brick and mortar come to clinic visits, right? So figuring out how they are changing might be important in how we deliver care to them. And we really saw the digital inequity in healthcare access during the pandemic, right? It really divided or it showed us how wide the gap is between the haves and the have-nots. And especially people when we were talking about video calls. Well, if you need video calls, if you live in a place without internet, you're using your data plan, and your data plan might not be fully unlimited for a lot of folks, and so you just can't do the video call like you hope to. So a couple of call to actions is just to really thinking about integrating technology support into primary care with attention to literacy issues. I had a patient who we met and did the visit, and I had handouts for her, and then that's when she told me I don't read, right? I completely missed that in my interaction with her. So she looks up things on the phone with the voice activated feature, and so that was shocking to me. But my bias, right? She's coming to clinic, she's seeking care, she must know how to read. And rethink youth and young adult access points and seek systems support to remove digital barriers. In Tennessee during the pandemic, Cherokee Health Systems negotiated with carriers of telephones to extend number of minutes for certain members that they cared for in their panel, so that they can have extended phone minutes, just minutes to talk on the phone, right? So digital is great, but it still doesn't close the gap or divide. And that kind of brings me closer to one of the reasons for the gap is the prolonged presence of poverty. And I think this is something that we all struggle with because it is the root cause and driver for a lot of things that we deal with in healthcare. And here are a couple of things just to kind of help us think. It is an out-of-focus priority for the US, right? It is not front and center. This is also one of those things from a policy perspective. I don't know if we'll get to a place where we're kind of going after poverty and eliminating things related to that. And the fault in our source for mental health is we disproportionately rely on evidence from middle and upper class samples. So a lot of our studies are done with people who have access to clinic, who have the time to participate in a study even when they're being paid. They have the literacy components at times. I'm not saying all studies, but the majority of our evidence base is built on that upper middle class framework. And so there's a big disconnect between what we know as evidence-based interventions and poverty. Right? And so that's one of the things that aches my heart for sure, something that I want to do everything I can to move towards eliminating. I'll show you a book in a second, Matthew Desmond, he talks about we are to take on the call to be poverty abolitionists, and kind of end poverty. If you're in primary care, likely you will interface with poverty routinely, depending on where you practice. And integrated care professionals, I think, have a moral responsibility to be poverty sensitive and advocate for its impact on health outcomes, right? Whether it's getting them free samples for medications as a lowest level intervention to ensuring transportation, food, electricity, those kinds of advocacy points. So what can we do? I think we need to integrate poverty awareness into training pathways. Are we sensitizing our trainees, future healthcare professionals, that poverty is a silent but an outsized influencing factor in the work that we do? And develop provider sensitivity to economic influences on health. Whether I think it's easy to say the patient is not adhering to my recommendations, it's harder to inquire about what their daily life looks like, what their living condition looks like. We had a patient on warfarin who came kind of unmanaged, and she was kind of managed for a while. And we realized well, the PCP was not very happy. And so we went in to do the consultation, and we found out that she had to move one apartment to not a better apartment, but the other one was roach infested. And that's the reason she's been not compliant for the past 2 weeks, right? And so that really changes how we then think about her non-adherence in a much different way. Account for poverty in our research. So when we think about clinical trials and other things, which economic strata are we pulling from? This book is really good. He documents policies. He really makes us feel uncomfortable because he talks about how certain policies in the United States are kind of welfare in reverse, the tax credits and other things that we get. So it's a really good study on poverty, and he's a really good scholar as well. And so the last one, thinking about is creating meaningful pathways for the workforce. And this is just really thinking about, do we retain the people that we get into the stream of work? HRSA and SAMHSA has really made large investments over the last several years. And at the same time, there's a lot of barriers for frontline clinicians. And I think Rochester's story may be different. I'm just kind of thinking like nationally. So for all master's level providers, there's limited career advancement. There's inadequate investment in their leadership. So I think most people want to grow and contribute and do meaningful things. And the lower compensation despite the increased demands for mental health. I like how when a national tragedy happens, they always talk about we need more mental health. We never hear about more mental health dollars, just mental health. And turnover, we lose a lot of people to non-integrated positions, which I think is a huge drain on the investments that it made. Systemic barriers, so greater advocacy for reimbursement. I was really glad to find out this morning that trainees get paid here, which is amazing. Only in 2024 did LMFTs and LPCs. Was that funny? No. So only in 24 we have Medicare and Medicaid access. And I think about the lost years of these two professions in being able to be an equitable partner in healthcare change. Because I'm an LMFT. When I got to my system, I was working myself out of a job because I could only hire LCSWs or licensed psychologists because they can bill versus me, right? Difficult path to full licensure, unpaid hours and supervision hours. So it's cost prohibitive if they come from an economically disadvantaged background. And graduates really try to make a lot of ends meet in their passion for this career. So a couple of things, which is creating billing pathways for master's level trainees under supervision, which looks like Rochester has that figured out. Special accommodations for primary care in rural locations. Really thinking about a national match for integrated behavioral health residency spots with compensation for doctoral and master's level providers. Pathways for career development with leadership trails so that we are not forgetting their desire to grow. Advocating for equitable pay, which I know is a long conversation. And look for meaning and engagement in their work because we don't want to lose people that we trained for years, right? We put a lot of money and effort and psychological energy into training somebody, so we want to see them for the long haul. The last one is just rethinking empirically supported treatments for integrated care. And this is an article that Patty Robinson or Kirk Strassel wrote in, I think, 2018. And a couple of big insights from that. If you guys want to look that up, it's actually a good read for a lot of us. So limitations for our current evidence support treatments are, it's very complex and labor intensive, requires specialized training and licensure, not designed for primary care or population health, and not a good fit for community care, right? So if we think about protocolized treatments and 12 sessions and all of that, it makes a basic assumption that somebody is willing to tolerate you for 12 hours over several weeks, which is a huge assumption, right? And it really doesn't help that we don't address the problem of poverty in that mix as well. So what if we shift the focus from which treatments work best for specific conditions to which treatments works best, fastest, with fewest resources, lowest dropout rates across provider types in diverse settings for patients with multiple conditions, right? So that's one of the things that we need to think about. In my current projects, we're doing some things to address few of these. We have a maternal health intervention program that we're doing where we're training community health workers to deliver acceptance and commitment therapy modules as educational modules to pregnant mothers or mothers who just had a baby or within 2 years of birth. And then we're also doing a pragmatic trial in primary care, which is going to be a very messy project, I can already see. But we're in the early phases of designing our clinic to do that. And we're basically saying there's no inclusion criteria for who the BHC or the behavioral health consultant sees, right? Because a lot of the studies, there's really clear inclusion and exclusion criteria. So we're getting rid of that. We'll see where it goes. No promises. So essential considerations for developing integrated care interventions: brief, cost-effective, patient-centered, obviously, adaptable to primary care workflows and time constraints. I don't need to tell you guys about the demands of time. And designed to address realities of primary care, which is comorbidities. You're not going to get the clean depressed patient, right? Or the clean hypertensive patient. You're going to get all of that in one visit. Social determinants of health, and of course, poverty. Deliverable by various healthcare professionals with different training levels. If you think about raising equity and increasing reach and access of the science that we know could be life-saving, and if we remove some of those barriers, what would that do to our rural areas, our poverty-stricken areas, in who is delivering these interventions, right? Now, I know that might make a lot of the guilds uncomfortable, and rightfully so, right? But at the same time, these are the things that we need to kind of think beyond for the future in increasing access. So, a couple of things: including real-world patient samples and studies, design interventions for primary care, test intervention effectiveness across different providers and levels of training. We don't need maybe master's or PhD levels for all the interventions. There may be a lot of things that community health workers can do. Prioritize solutions that can be deployed quicker in population health settings. Minimize modular sequential treatments with high demands of showing up, demands of spending an hour. And use context as primary lens to understand the set of options for treatment versus determined set of pathways, which is basically saying, treat the person, not the problem, right? If you're context sensitive, then you know adherence has a reason to exist and non-adherence has a reason to exist. And then you kind of work with them accordingly based on their values and things that matter to them, and things begin to trickle in the right direction. So these are the few things that we've thought about. Hopefully this is kind of jogging your thinking a little bit. I don't have much more to say other than what other forces do you guys see? Yeah, so I think rest are just summary slides. It's not very important. So I'll stop there and I'll take questions and conversations.
Thanks so much, Dr. George. That was fantastic, very inspiring. Okay. You already answered the interpreter's questions, I take it, yes?
Yes.
Okay. So, yes, Dr. Nasra, go for it.
Thank you very much. George Nasra, I'm a psychiatrist in the department. Well, thank you for this uplifting, positive message. in spite of, not so uplifting and positive times we're in. So thank you for that. I've noticed that you, there's only so much you can cram into 1 hour presentation, but I've noticed you did not mention the value, the financial, monetary value of integrated care in your presentation, which is something we try to kind of factor into our strategy here when we talk about integrated care implementation, to say, investing in psychologists, psychiatrists, therapists in your practice will actually have a return for you. I'm just wondering if you can comment on that.
Sure, I think it's between Parinda and myself. I think we are so biased that we know that it's true. We didn't think it needed to be said, but I think you're right. And I guess the bigger curiosity for systems, and I don't know if Rochester has an answer or other systems have an answer. I always hear like the return on investment is this, and then I'm always curious, if we followed that dollar, where does that go? And my sense is it needs to be reinvested into the workforce development so that people are paid for what they're doing, the life-saving work that they're doing. I also think, I don't know, like alternative payment models have a lot more to do here, I think. Our traditional fee-for-service will never kind of make it there, right? Like, I can tell you from our practice, if they collected all we bill, we should be getting like, $15,000, $16,000 a month. We're collecting like $3,000, right? So there's a lot left on the table, but that's also part of the fee-for-service system, the negotiated rates for insurances, for the codes that we use. So I think in an alternative payment model that has a lot more value, I think, because there's more oil to make it work, versus in a fee-for-service, I think you can break even, unless you're an FQHC.
So if I could add, I think another part of the problem is our studies don't really capture all the ways in which integrated care can affect the system, whether it's how the team feels better and functions better, the various ways in which the patient is able to contribute in their own workplace. It's a complicated biopsychosocial thing, and it makes it difficult to really nail down what are the positive effects and any negative effects.
Yeah, I agree. I think some of the things that the aspirational stuff, we don't have the right research methods or technology to capture that, I think. I think that's why we lose some audience to that idea.
Work on that, would you please? Okay, good. Other people's comments, experiences, suggestions, questions?
You had one come up on Zoom.
Location, location, location. This comes from Odysseus. We need more inner city biopsychosocial centers as a nation. Like the Odysseus, I guess, is the medical director of Catholic Charities on North Clinton, which I didn't realize, but he knows from a day-to-day experience that that's so. And it's true. I would love for us to have a clinic in the more inner part of the city. And I know that's something leadership would like too, but it's sort of complicated, as these things always are. Other things that you think could help that, maybe we're not paying attention to. Dr. Rosenberg.
It's not a trick question, but I do want to hear more about the creative destruction. It might say something about me. It's probably diagnostic, but in the model, in order to get to the good spot of that shape, we need to creatively destroy, and I would love some suggestions.
Some suggestions. You want me to solve the problem today, right now?
I think she wants you to tell us what we need to destroy. Is that true?
Yeah, I can kind of
Part of
like
it's payment system.
said, yeah, I think payment system is a bit, I can think out loud just from our clinical growth, right? And this is more self-reflective than maybe policy level. And I think a lot of my colleagues that I've talked to may share this too. I remember growing into primary care and beginning as an initial behavioral health consultant and thinking, oh yeah, I'm the behavioral guy here, right? Like I'm here to help improve some of those things. And it just dawned on me that over time, I'm a primary care provider who's behaviorally trained. And that subtle shifts has ripple effects on how I behave or how somebody else behaves in an environment. Because now, if somebody does not have their diabetic foot exam, it's a concern to me because I'm part of the primary care team, right? And versus me just being the mental health guy who can help with a few of the things that they're coming into me for. If someone is on asthma medication and they don't have an asthma action plan, that deeply concerns me. And so that's like ways of like that creative destruction, which is kind of letting go of my identity of what I've been told as who I am versus becoming a primary care member. That's just like a simple example of that, right?
So if we all have a biopsychosocial model and tend to that, the other thing I just wanted to say is to Zipporah, you know what we really need? More interprofessional training in the workforce. So we have a shared mental model and we know how to work together and what we're good for. So I'd like you to think about that.
Also to that point, I mean, you mentioned the need for flexibility.
Yes.
You mentioned at the beginning, the Blockbuster, Netflix kind of contrast. Here in Rochester, we have Kodak, the Kodak story
Yes.
as well. So we're familiar with what rigidity can bring.
Correct.
Oh, sorry. So the point is, I really want to emphasize what you said about the need to be creative in our thinking.
Yeah.
When behavioral health integration doesn't have to be traditional mental health
Correct.
care always. So we have to let go of some things to be successful in this
Absolutely.
integration venture.
Yeah.
So that may be a form of destruction. It's letting go of what we are comfortable with.
Yeah, and I think there's a guy named Vikram Patel. He's a psychiatrist. He does a lot of global work, and he did a lot of work in India, and then he's done, I think he's at Harvard or somewhere in that area. But he has a book called Where There Is No Psychiatrist. And in that, it's just like a very bare bones explanation of depression, delirium, anxiety, schizophrenia. And it's used to train equivalent of community health workers in other countries to tend to the mental health needs, right? What more is more biopsychosocial than community taking ownership of their own kind of healthcare and their own agents being the healers who make that happen? So I think letting go of that too, right? Who delivers the care might be another creative destruction point.
Right. I know in Texas, you're training at the associate degree some people to especially be behavioral health interventionists in the collaborative care model, for example. I know we have to stop. We could keep at it because we have a lot to work on in this area, but I really please join me in thanking Dr. George for a great talk.